Well, hello and welcome to another episode of Essential Implementation. This is a quick one today. I just wanted to talk about de-implementation. So the case for de-implementation, I think this is an important topic, particularly in the current climate. I've spoken a lot about implementation in my other videos, and I mentioned I did a video on how to implement effectively. Well, I said implementation can only take place if teams have the time to engage in that all-important within-system learning, ongoing problem solving, have the time to understand their context, to make a plan, to keep meeting. They need time to implement. And very often, any time away from the patient can be frowned upon, particularly within the media. And so it's difficult for these systems that are so stretched to give that time to, say, clinicians, nurses, could be school teachers, anybody that might be involved in the implementation process. And right now there is really very little capacity for this kind of implementation, these kind of improvement processes. I mean, in 2019, here in the UK, in the National Health Service, the King's Fund and the Health Foundation both reported that the staffing was at breaking point. And then COVID struck. And so these individuals who were already struggling to meet demand were now even more exhausted and have increased post-COVID workloads. And so what we've seen is a lot of healthcare staff leaving the health service. And of course, this is a vicious circle, because if your colleagues start to leave, now you're left with even more work to do. It's even harder to take time off, and you're going to be even more burnt out. And that's what we found from a number of surveys. In 2020, 44% of staff reported feeling unwell because of work-related stress. And another survey with, of course, UK, Poland, and Singapore found 67% of healthcare staff reported burnout. 67%. That's a huge portion. And actually, just to give it a bit of more context, this year alone, 40,000 nurses have left the UK National Health Service. So it's becoming increasingly difficult, not only to care for patients effectively and give a good service, but it's even harder to implement anything and to do kind of improvement processes. So what does this mean for implementation? Well, as I said, there's very little capacity to do implementation or improvement, because most places won't be ready. I talk about readiness quite a lot on this channel. Look at it again as motivation and capacity. Well, even if they're motivated, they might not have the time or the capacity, or they may not be motivated and have capacity because maybe they've got the capacity, but there's other things they need to be doing that they feel is more important. And a lot of these people are the experts of their own setting. So I'm aware that we have to be careful not to assume we know what's best. It's often these people are in this setting every day, day in, day out, and they'll often actually know what's needed. And the risk is, if we do keep mandating things and getting them to implement more and more into a system with very little absorptive capacity, we could increase burnout. That's the real risk. And I got a lot of my thoughts around this. I'd already been thinking about de-implementation for a while, but this editorial really, for me, just laid out some brilliant points. Now, this was by Rebecca Lawton. She was the lead author, and she works. I spend a lot of time at the Bradford Institute for Health Research in the UK. Rebecca's also spends a lot of time there, and she does some great work around patient safety. She does a lot of quality improvement work. And so she's talking at this from a QI, quality improvement perspective. But I think it crosses over into implementation. And she's really just talking about the title, the self-limiting nature of QI. Can we improve the quality of patient care while caring for staff? And what she's really, if you just look at the introduction here, is that they're arguing that quality improvement as currently deployed is self-limiting. In other words, if left untamed, it will fail to produce valuable change and may have a raft of negative consequences, including stress, reduced engagement, and burnout among healthcare staff. So these, large efforts to improve the quality of care, as well as large efforts to implement things to help patients, could actually make things worse, because we could be increasing stress and burnout. So this is a huge issue we need to be aware of if we're involved in implementation or quality improvement. Brilliant editorial, recommend reading it. Look at Rebecca's other work as well. Really great stuff. And this is another paper. This, I think, was like a sister editorial or sister viewpoint that was put with Rebecca's paper. And again, talking about quality improvements and could it be precarious and self-limiting? And they also go through a lot of detail on that. Is quality improvement as a primary approach to healthcare potentially self-limiting? Our point of view is yes. It's great to see work like this being published. It's great to see scientists really getting to speak their mind. And I think that's what good science is based and built around. So I was really pleased to read this stuff. Now, I just wanted to, again, this raises questions about implementation. Could implementation add to burnout? Might we need to de-implement? I think, so these papers were about quality improvement, but as I say a lot in my other videos, good implementation often requires a kind of quality improvement process, right? You could see it as an improvement process itself. And so, implementation could be linked to burnout. What does it mean? Well, what about maybe we could de-implement things to help that? And this is one of the recommendations of the editorial. And I just wanted to, well, firstly, what I want to do is just, there is a science of de-implementation. There are the definitions. There isn't a lot out there. I mean, there's quite a few papers defining it and talking about what frameworks we could use to measure it. But it's still quite a new thing in a way. I haven't seen many examples of it actually being tried and tested. And again, we want the practical how-to of how do you de-implement. We don't just want to know what the barriers are to it. We want to know how to do it. But de-implementation, abandonment of medical practices or interventions that have been found to be ineffective or harmful. So it has a focus on things which just aren't helpful. That's what and that's logical, isn't it? So we should maybe, it's saying we can remove, replace, reduce, or restrict low-value care practices. So it's not just about getting rid of things. It can be a partial reduction or a replacement action. In the editorial, they think they use the phrase decluttering. And I think you imagine, I don't know, in a hospital on a ward with lots of nurses working really hard, there are all sorts of processes that they have to follow to maintain quality and safety for the patient and to do good care for the patient. But it sometimes be the case. I've heard about, there'll be a process of kind of noting down what medications have been issued that day or something along those lines. But it'll be replicated 3 more times in other processes. And so the nurses are kind of like, well, do we need to do it 4 times? Could we maybe just do it once? So maybe that could be like a definition of, or a one sort of view of decluttering. Now, yes, the recommendations. Again, the editorial, both those papers I showed you really do lay these out very well. So have a read, just a brief kind of overview. And I've sort of translated them into implementation. So not just quality improvement, but I think we could apply them to implementation. So we might want to think about the impact of implementation on staff well-being and measure that throughout. So whatever we're going to implement, we want to think, well, actually, what impact is this going to have on rates of burnout? What impact will this have on emotional distress and things like that and stress levels? And if we're going to go ahead with this, why don't we just keep measuring the staff's burnout levels and stress throughout, right? And keep talking to them. And maybe we could use lightning reports to do that. Hey, that regular, in my other videos, I talk about that regular contact. Assess readiness. This is really important. Always be assessing. There's no point us implementing across 100 sites if 80% of them aren't ready. Because if they're not ready, they don't have the motivation, they don't have the capacity, we're likely to waste a lot of resource and increase a lot of burnout. People worry, understandably, about healthcare inequalities, and everyone needs to have the same thing. But we also need to acknowledge that every site is its own site, will have its own needs, will be facing its own contextual barriers. So maybe what we need to, if we want to reduce healthcare inequalities, be thinking, well, what does everybody actually need? And it may be that those 80% need something else. And if we address that and we work with the staff to implement things that matter to them and that they think they need to do better patient care, that's another way to reduce healthcare inequalities. I think giving everyone the same thing isn't necessarily the solution. I think it's working with sites to give them what they feel they need. Number 3, prioritize projects that make it easier for staff to care for patients. Pretty obvious one. Allow staff to pursue what matters to them. Decades of research has shown that if a team really feels that what they're implementing is important and they make it their own and they get to sort of design it to fit their setting, you're going to get a lot better implementation outcomes. But a lot of what we have currently is a lot of top-down mandating of various interventions, various processes, which can increase burnout and doesn't get implemented as well. It's a lot harder. And just consider de-implementing low-value care practices. So they would be the recommendations. Taking actions like this will hopefully decrease burnout, which will benefit patients. So if we empower staff if we empower frontline healthcare workers to really do what they feel they need to do to get better care for the patients, to improve their work environment, to decrease burnout, that will in itself probably lead to better patient care because they'll be less burnt out. So the good news, I suppose, it's still kind of early days, but I think we can use a lot of our current implementation approaches to de-implement. We can use things like implementation frameworks, theories, models to diagnose the context for barriers and facilitators to de-implementation. We can plan for de-implementation. We can monitor and evaluate de-implementation using a lot of the same approaches and tools that we would for implementation. And we can also use improvement science techniques to support the doing of de-implementation and learn the how-to of de-implementation. So, I'm very keen to try working with a team to really understand what matters to them, what maybe is a low-value care practice that we can de-implement, and use things like lightning reports, regular contact, the CFA, those sorts of frameworks to really just help facilitate the within-system learning that would need to happen to de-implement. And if that goes well, then maybe you could do your randomized control trials after that. But maybe it's a good idea to start with one setting first. So that's all I've got for today. De-implementation. Hope that was useful. If you got any questions, you want to get in touch, please feel free. Thanks for listening. Bye-bye.